Uh, just overwhelmed with the success of last week's sessions and today's. We've had some outstanding talks and discussions, and moving on, we go on to the panel discussion on the evolution of insulin use in pregnancy. And for the same, we have three dynamic experts, three wise men, three men who have expertise across the field or spectrum of diabetes, but remain highly passionate about hyperglycemia in pregnancy as such, which is a very niche area of expertise. So with that, I welcome Dr. Sunil Gupta, sir. He is a physician diabetologist from the lovely city of Nagpur, president of DIPSI or Diabetes in Pregnancy Study Group of India, treasurer of RSSDI, and besides all his academic clinical accomplishments, he remains extremely passionate about patient education through his Hello Academia, Hello Diabetes Academia, and besides all the awards that he has received, he's the only diabetologist from India to have received the Outstanding Young Person of the World 2002 award from the US. Welcome, sir. We have another prolific expert, Dr. Anuj Maheshwari, sir, a physician diabetologist and a DMB PhD teacher from BBD University, Lucknow. He is the current National Vice President, RSSDI, Governor of American College of Physicians, Indian Chapter, National Academy Coordinator and Treasurer for the Indian Society of Hypertension. And amongst all his outstanding awards, he has also received the R.G. Wegman Oration from the Indian Society of Hypertension in 2015. With all the orations and awards sir has received, he continues to work to turn things around. Welcome. We also have Dr. A.G. Unnikrishnan, sir, who is an endocrinologist who also wears multiple hats at once. So besides being a practicing endocrinologist and CEO of Chelaram's Diabetes Institute, which we all know is a premier IDF certified institute in education and excellence in diabetes care in Pune. So he heads the clinical care, research, education, and also oversees a philanthropic rural diabetes care program at the institute. Among all his academic, scientific, community, and research activities, they have been well received, and he has been awarded the Subhash Mukherjee Oration Award from the Endocrine Society of India and the Srivastava Award of RSSDI for his contribution to the field of diabetes in India. Welcome, sir, to the panel discussion. And to just move on, because I want you all to get the maximum benefit from this, this trial that we have today. I will move on to the first question, and I would like to bring Dr. Unnikrishnan on the spotlight. So as we understand, sir, insulin has always been the gold standard for treating hyperglycemia in pregnancy until metformin became a popular choice after the results of the MIG trial that had been released. So is this true, and what are your thoughts on the same?
So it was after the publication of the MIG study, metformin in pregnancy, gestational diabetes came into light. Now in the MIG study, the authors, it was a study from Auckland and Australia. They randomly assigned women with gestational diabetes between 20 to 33 weeks of gestation. And the primary outcome of the study was a composite of neonatal hypoglycemia, respiratory distress, need for phototherapy, birth trauma, an ABGAS score which was low, or prematurity. The study showed that in people with women with gestational diabetes, metformin alone or supplemental insulin not associated with any excess perinatal complications as insulin alone, and that women actually preferred metformin as a therapy. So it was after the results of the study that metformin sort of came into its own. And since then, there have been several studies. In fact, the MIG cohort has been followed up into, children have been followed up into their early phases of growth, where they've also shown that the subcutaneous adiposity is higher in children with who are born to mothers taking metformin. The overall adiposity did not change, suggesting that there may be additional benefits of metformin as well. So these were some of the results. And yes, you are right. after the mixed study, metformin for gestational diabetes came into its own. In the UK, metformin is considered to be one of the important treatments for gestational diabetes. In the US, I'm told that insulin is usually preferred. In India, I think we use our judgment and we offer metformin to women unless we think there is a compelling need for insulin in clinical practice that is done. But thank you for the question.
Great. Thank you so much for enlightening us on that, because I think that's important from the historical perspective also, that around 2008, when the MIG trial was released, I think metformin did become popular for a while. With that, Dr. Gupta, sir.
Purvi, it is equally important to mention here that we have the Government of India guidelines now for management of GDM, and they have mentioned that after 20 weeks in GDM, you can use metformins in GDM women unless and until it is contraindicated. So like you have UK guidelines which are favoring metformin, like you have US guidelines of favoring insulin. We have Government of India guidelines for management of diabetes in India by Ministry of Health and Family Welfare. And they said 2014 as well as now 18, they have added that it can be the first choice in patient unless it is contraindicated. But of course, there is always an apprehension what Dr. Unni has raised in a very, very subtle way, that there are some trials which have been followed, that MIG tofu trial, which is follow-up of these children of the offspring of diabetic GDM mother versus those who are given metformin versus insulin. And now the data is available up to 9 to 11 years also. Earlier it was 4 to 7 years, now 9 to 11 years old children. And they also have to have been found to have increased adiposity, the fat and visceral obesity. So that is what is an apprehension about metformin at this juncture of time. There are also trial on metformin that you have MITI trial. MITI trial is in type 2 diabetics who have been put on metformin and insulin versus insulin alone preconception, and they have been continued. So GDM is a trial where the key period of up to 8 to 10 weeks of organogenesis was spared. Metformin is given in the third trimester, but here the metformin is there from the period of conception till delivery. And now they have got the outcome data again showing very promising data that it does not cause much of the issues as far as neonatal outcome is concerned. But when you talk about metformin, it also mentions very important MITI trial, type 2 diabetes, metformin with insulin versus insulin alone. Those babies born to metformin group have more number of small for gestational age. So that's another area where possibly we'll have, because everyone should know that metformin crosses the placenta almost up to 50 to 70%. Insulin doesn't cross the placenta. And that's why there is some apprehension raised in last few days.
Great. Thank you, sir, for elaborating on the evidence that supports that. And I think, so the theory underlying this entire stand is that, metformin does cause a little bit of a micronutrient deficiency intrauterine, and then there is a catch-up growth, so to speak, once the baby is delivered. And that is what leads to...
Purvi, one thing I would like to add here,
Yes, sir,
although
please.
I know that I don't want to go into the detail, otherwise this discussion may go shift to a metformin instead of insulin. But one thing I always appreciate in Indian population, that Indian population which enters into the pregnancy, that is not so much BMI as the BMI was there in the MIG trial. And metformin is against the basic principles of the pregnancy. Because basic principle of the pregnancy is the insulin resistance. Pregnancy is the only condition where insulin resistance is welcome because it is required for the growth of the child which is in the womb. And once we start using the metformin, once we start preventing the insulin resistance since from the beginning, this is against the natural physiology of the pregnancy. What I said 2-3 days before in some other symposium.
I heard that, sir. I heard that.
But repeated here, but people should also be taking care of this thing in the mind, despite all the arguments which are being given in the favor of the metformin. As Dr. Sunil Gupta said very rightly, after 20 weeks of the pregnancy, we can think of using this up to certain extent if the mother is not so much BMI, so much obese, which kind of the mothers are usually not seen in the India in the pregnancy, in the age group in which they get the pregnant, usually.
So my question to you would be, sir, is insulin really the gold standard now for treating all cases of hyperglycemia and pregnancy? And would you begin insulin therapy for someone who comes to you at whatever gestational age, but with an HbA1c of 5.8%?
For me, or Purvi?
Dr. Maheshwari.
Okay, thank you.
Come back to you, sir.
Thank you, Purvi. I think that every person, if he is having hyperglycemia in the pregnancy, first should be tried for the medical nutrition therapy. If if she is not being able to get enough control, desired control on the medical nutrition therapy, insulin should be tried, whatever the HbA1c is there at the entry. Because in gestational diabetes, always you will not get very high HbA1c. You will get HbA1c almost near to the control, but because it is the gestational diabetes, because it is for the pregnancy reason, so you need to control that. And if you are not being able to get it less than 120 by medical nutrition therapy or by doing the diet and exercise, then prandial insulin is the only answer. Gestational diabetes, usually we don't get the fasting hyperglycemia. So mostly we get with the prandial insulin easily. But if we have some component of the fasting hyperglycemia, suppose if person is having insulin resistance, then in that case, we can use the premix insulin in that case to take care of that basal hyperinsulinemia, basal hyperglycemia, whatever is being there. That is my take.
Great. Thank you, sir. Dr. Gupta, would you like to add to that?
Yeah, I feel Purvi, a question is very specific here, addressed that if someone who is already just GDM 5.8, you said HbA1c, so very well controlled. Now, should we be going for insulin versus metformin? I feel this is one of the most difficult question someone asks us. Now, we should know that there are some relative contraindications for metformin. And that is one thing which everyone should know. So if the person has a past history of any bad obstetric history, some women who has women having a small for gestational age baby, some women who has associated vasculopathy, preeclampsia, hypertension, someone who is intolerant to intolerance to metformin, in such individuals, metformin is not a good choice, and I will certainly start them on insulin. Similarly, some women who's being detected in the first trimester at the time of conception, I'll again avoid giving metformin, and even if it is 5.8, I'll start small doses of insulin in such cases. So it has to be clinically, and every time whenever you give metformin, it's better you write a sentence below that you have tried to convince women for insulin. If they're not willing, then that's why you are giving insulin. Of course, the rest of the area has already been discussed, but these are some absolute indications for insulin. Let me share with you, insulin is the drug of choice in pregnancy, irrespective. Any global guideline you just open and you will see insulin is the drug of choice. Of course, it has to be, of course, of the choice of women. As in big trial, they have shown those are those on metformin, they like the therapy. Naturally, everyone who is being given oral drug, certainly they will like it.
Thank you.
I'd just like to add to that. So the choice between nutrition, metformin, and insulin is basically a clinical one. So instead of going only by the glycemic control level, one could also look at the maternal-fetal characteristics, which will predict. For example, if there is a suspicion of small for gestational age, for example, you could go for insulin therapy, and you might like to relax the goals, because if you aggressively pursue the goal of glucose control, you might cause more small for gestational age. Similarly, when you find, for example, the abdominal circumference is suggesting there is macrosomia, you might like to go for metformin or insulin, maybe both together, and maybe go a little more aggressive on the goals So depending on that, abdominal circumference or other features of macrosomy, that could be added. Now, the Indian guidelines have endorsed metformin. The UK guidelines also offer metformin, unless, like Dr. Gupta said, there are compelling needs for indications for insulin, like SGA, vasculopathy. But the vast majority of gestational diabetes is predominantly postprandial, and nutritional correction is probably good enough for the majority of women with gestational diabetes. Where in doubt, I think insulin is a drug of choice.
I think
Can I ask a question here to the
yes,
panelists? Sorry to
please.
intrude. So, great going and all ideal answers, I must say. One of the situations that very often we land up is when the obstetrician or gynecologist is actually asking us to look into the sugars, even if the sugars are not high, but they are noticing some polyhydramnios, some increased liquor, and that is the commonest time that they start getting worried. Do you all face that issue, and should that be a driving force to consider treatment if otherwise you were doing well with medical nutritional therapy and you were hanging in there? Does polyhydramnios increase liquor push us, or should it push us to start insulin or metformin or whatever?
Manoj, that is an area where the role of continuous glucose monitoring actually appears. And it has been already hypothesized long back that if you have got somewhere where you have apparently everything normal, still you are getting some unwanted results like polyhydramnios in this case, one should always go for, it could be because of the glycemic variability. This has been hypothesized almost 10 years ago when AGPs and these things were not available. When our professor Sam GP Moses always used to say, even if someone you feel that this particular case is going little wrong somewhere, start a small dose of insulin, maybe 2 to 2 units of insulin, that will also work. That's what we have learned from our professors. And with all due respect to it, what very rightly Unya said, we should not be just focusing on the glucose or the readings, but also the good communication between the investigation results, the obstetrician's findings, and the blood glucose reports all should combine together. Such situation, metformin will possibly not be a good choice, and insulin, maybe a small dose of insulin, see for the glycemic variability, any spikes in between. No one monitors post-dinner blood glucose. Maybe in South India, we have a lot of post-breakfast blood hyperglycemia. Our own data, which is already published in 2 different articles, 2 different papers. And we have shown that it is not the post-breakfast which is highest in Central India, it's the post-dinner which is highest. And no one in our country advocates monitoring post-dinner blood glucose regularly. Occasionally they ask. And if you see post-breakfast 110, post-lunch is 130, and post-dinner 170. Insulin requirement almost get double than the pre-breakfast dose. Someone is on 2, they will say 4, and then possibly it will be 7 or 8, something like this. And this has been documented. So I feel somewhere we are missing out these postprandial spikes, which could be the reason.
Very well said. And I think one important thing that came out was medical nutrition therapy, because a lot of these borderline hyperglycemic cases, I believe at least we have experienced that very well, they can be managed with just medical nutrition therapy alone. Dr. Uni, you were saying something.
Yeah.
Okay, I think Dr. Anuj wants to say something.
No, only you complete, and
I was just trying to say that, one of the things that correlate with polyhydramnios is the maternal BMI. So, of course, there are insulin levels are also high in polyhydramnios, suggesting some degree of insulin resistance, but it is a medical. So this again highlights the importance of weight control and optimization prior to pregnancy. So that could be an important nuance in preventing these problems, because that pre-pregnancy insulin resistance may be a contributing factor. Just wanted to add that point.
So then only would metformin be better than insulin for such patients?
Well, so when I used to be a professor at the at Amrita Institute of Endocrinology, I used to say only insulin. But now that I'm seeing the real world practice, I'm quite pragmatic, and metformin is preferred by a lot of gynecologists, and for good reason But having said that, like Dr. Gupta said, it's good to weigh the evidence and choose metformin for the routine, young, complication-free, vasculopathy-free gestational diabetes. And wherever in doubt, choose insulin, because that is the treatment of choice, and it always seems to work very well. But yes, metformin definitely I feel has a role, and the UK guidelines endorse, the NICE guidelines do endorse metformin as a initial choice. But yes, I think wherever in doubt, insulin is the go-to drug, and there are several regimens for that, as you know.
Just the irony that, metformin label still doesn't carry the fact that it is approved for pregnancy, use in pregnancy. So I think there is a little bit of a mismatch there, but yeah. Dr. Maheshwari, you were saying something, and then I would also like you to address which insulin regimens you prefer in pregnancy, and should we initiate with basal or premix in pregnancy?
Yes, Purvi. My take on this was that whenever this kind of the situation arises, as Dr. Manoj Chawla was saying, this is mostly, as Dr. Sunil Gupta has already highlighted, this is mostly because of the poor monitoring. And many of the times this poor monitoring is our avoiding tendency also. Sometimes we don't want that patient to be on the insulin, and we keep on understanding that MNT is doing well and MNT is doing well. And we ask the patient to get the fasting, and PP fasting is already normal. And PP she is doing after a little breakfast, and that is coming normal. And everyone is very happy. Nobody is taking care of that, what is happening after the dinner and after the lunch. So these are the situations because of what these things usually arise. But again, I would like to say that in such situation, metformin again would be not a good thing to start with, because these kinds of the situation again would increase the decrease the insulin resistance, and fetal growth will be jeopardized further. So fetal growth would be the best parameter whether we should start with the metformin or not. Otherwise, if we are not having any information regarding that, better to start with the insulin. Mostly physicians don't have this kind of the information once the patient comes to them. As far as your next part of the question is that which regimen should be preferred. So obviously in gestational diabetes, I prefer the prandial insulin. Mostly prandial insulin works well. Sometimes it works well only with the largest meal. Later on, it works with the more than one meal. Sometimes we just break the breakfast into the two parts, and it works well, keeping the postprandial hyperglycemia up to the desired level in minimum amount of the insulin. But if the person is having little insulin resistance before entering into the pregnancy, or the female is obese, in such situation, we require little bit of the basal insulin also. Then premix works very good in such situation. And many of the times I have tried that in the morning I am giving the premix 50-50, and evening only the prandial insulin is working enough, or post lunch only the working prandial would be worse. Sometimes it also happens that we are giving the 50-50 in the morning, and that is also taking care till the lunch. And in the evening, we shall be requiring only one shot of the prandial insulin, and it is doing good. So that is quite individualized whenever we say which insulin regimen is required and how to give that. That is my take.
Thank you. Thank you so much for elaborating on that. Dr. Gupta, sir, do insulin analogs have a role in controlling blood glucose in pregnancy?
See, when it comes to gestational diabetes, as Unni has already commented, that it is one of the JDM, practically a postprandial hyperglycemic state. You have post-breakfast, you have post-lunch, and you have post-dinner. So it is the postprandial hyperglycemic state. In such situation, best is, of course, the analogs, because you have aspart available, you have lispro available. These are the only two insulin analogs which are being approved for use in pregnancy. Glulysin is not been approved. Of course, Fiasp is, because aspart is available, so fast acting aspart is also approved. So these are the three rapid acting analogs which actually controls blood postprandial blood glucose very well in GDM whenever it is required. Then second part of it is, if someone has fasting hyperglycemia, then of course you already have regular insulin can be used, NPH insulin can be used. They are all very much indicated. But when it comes to analogs, you have only Detamid, which is being approved for its use. Glargine, there is a new recommendation till 2015, Purvi. We had classification of use of drug in pregnancy. It was A, B, C, and Glargine till that time was in category C drug for use in pregnancy. But after 2015, that classification has been removed, and now they have a individualized. It has been said that FDA USA says that if some particular type 1 or type 2 diabetes already taken Glargine, and if clinician feels that by withdrawing Glargine, the glycemic control may go haywire, and that can affect the fetal outcome, in such situation, for the safety of the patient, Glargine can be continued. Otherwise, one should take aspart or lispro rapid acting analogs and detamir as a long acting analog. There is no safety data available in pregnancy of degludec at this moment of time, and of course Glargine 300 data also not available for safety. Only Glargine 100 data is available. That too is it's not a RCT trial, so there is no randomized control trial of Glargine in pregnancy. Whatever data is a retrospective data and observational studies.
Great, thank you so much. You elaborated quite a bit on that. So the message is very clear as to which insulins are safe and approved for use during pregnancy. Dr. Unni, is there a maximum insulin dose limit during pregnancy, and how do we get past that? I think you partly touched upon it, but if you can clarify that for us.
So I think by far my choice of insulin regimens in pregnancy is detamir and aspart, and that's because of its very low mitogenic, effects. The ratio mitogenic to metabolic ratio, or the IGF-1 stimulation is very little these drugs, and therefore the risk of the perceived risk of teratogenicity is low with these drugs. So given the patient is on say aspart and detamir, and if the dose keeps going up, you have three choices before you. The first choice is what I like to do is I like to split the detamir into two. So I split the detamir into two because all said and done, detamir acts very well for 12 hours, though it does have an action for 24 hours. So the first thing I do is I try to split it into two. The second clinical aspect I'd like to look into is the possibility of, if the insulin dose keeps going up, I look at what could be the reason for that. Of course, we are all specialists here, so we will look at the insulin technique and the cartridge and the injection and where they have purchased the insulin from. Sometimes, insulin from an online source or not a very reputed source, maybe that insulin quality may not be that good, etc., etc. But beyond that, adding metformin I have found is useful, especially when the insulin dose goes up. And two clinical clues I find to suggest the need for metformin as add-on is that some of the women start complaining of lots of hunger. That's a time I think metformin really works because it reduces the appetite. Second is, with high doses of insulin, there is a specificity spillover syndrome where the IGF-1 receptors in the neck are stimulated and you start getting the acanthosis nigricans color towards the end of pregnancy, which is also worsened by the insulin resistance. These are two clinical clues to suggest that metformin may be added. The third, of course, is the most simple thing to do, is to relook at the diet, maybe use CGM, find out, the patient herself can find out what dietary changes need to be made and work intensively with the nutritionist. Some of these patients are on daily, on a daily basis, they are in touch with our diabetes educated nutrition. These are some of the things that can be tried in clinical practice. Of course, looking for other endocrine causes, etc., is very rare, but if there are some clinical clues, you could look at them. And of course, other rarer phenomena like insulin resistance, type B syndrome of insulin resistance, insulin anti, these are all extremely rare. Usually, you see this happening in women who are obese and taking a high dose of insulin early on, their insulin requirement goes up.
Very comprehensively explained. Thank you so much for that. And we have just like 3 minutes more, so I'm going to request a very quick answer to the next three questions. So, Dr. Sunil Gupta, sir, where should a pregnant lady inject insulin? They're often afraid of injecting in the abdomen. So, that's important too, injection technique.
It's more psychological than the factual. So, if they can take insulin anywhere. Of course, when they have psychological issues, then we don't disturb that. And we can ask them to take on thighs, or I'll usually prefer abdomen as thighs, the best one. And then third, of course, is but they can take insulin anywhere they want. And that myth of not taking insulin abdomen, I feel that should be removed from the mind, because the needle which you are using is too small to go anything. But psychologically they have some this issue. So, but there's no data which say that we should not be taking insulin. And there's a good data what Unni has said, that adding in a metformin to high dose of insulin, there's a good data paper available on these lines. And one rare, and if I don't know, but if you allow me to speak for 30 seconds, we have in 2 or 3 such patients with too much of high dose of insulin. You ask how much is the highest dose, but all of us will say that there is no mathematics involved here. It has to be individualized. They can get to any numbers. I had one patient who was started with 85 units in the initial stages, went up to around 135 units of insulin per day, and she was put on pump. She non-affordable. We took pump on higher in last say around 12 to 14 weeks, and she could do very well in the last 2 to 3 months. So we can take even sometimes help of such pumps, which can allow you to have good glycemic control. And very nicely said by Unni, determined when you require higher dose need to be given twice a day. It will not be able to cover with once a day. It's not sufficient.
Great, thank you, sir. Dr. Unni, that brings me to the final question for you. For type 1 diabetes patients, what do you prefer? I mean, if they can afford and if they monitor well, if everything is optimal, then what is your preference? MDI or multiple daily injection therapy or insulin pump therapy? And why?
I think both Dr. Gupta and Dr. Anuj Maheshwari have talked about the importance of insulin. And wherever a type 1 diabetes enters pregnancy, if I can choose, if cost were not a factor, then I'd certainly prefer an insulin pump with continuous glucose monitoring. But we live in India, where the sheer burden of a disease, the financial burden of a disease like diabetes, can coexist with ground realities such as affordability, accessibility to medicine. So given that situation, we often make do insulin injections, and it's not, we can manage these patients quite reasonably well. But given a choice, yes, insulin pump and continuous glucose monitoring would be what I'd prefer. And we do have such patients who have successfully managed pregnancy with both pump and CGM throughout pregnancy. We've had that many times, type 1 diabetes people.
But there's no role of premix, please. Our delegates type 1 diabetes, please don't use premix.
Very important point.
Yeah,
thank you for
absolutely not. Premix should never be used in type 1 diabetes, as you know, but that goes without saying. I think very important words by Dr. Gupta. Type 1 diabetes, basal bolus is the way to go, and of course insulin pump for the affordable.
Great. I'll have Dr. Maheshwari have the last word here. So what are the risks associated with insulin use during pregnancy? And if you can, I know we discussed, Dr. Gupta also highlighted very well the monitoring, but if you can summarize, the monitoring pattern that we suggest in insulin. I mean, in pregnancy, sorry.
Anuj, you're muted. Anuj, you're muted.
You need to unmute, Dr. Anuj.
Sorry. As far as the risk of insulin is concerned in the pregnancy, I don't find any risk other than if a person is allergic or having some tendency of the lipodystrophy, or somebody is having the hypoglycemia. Hypoglycemia in pregnancy, I do not find a bigger risk, because in normal pregnancy also, some sort of the hypoglycemia keeps on going. And it is not very much different than the hypoglycemia, what we call in non-pregnant diabetic individuals. So many of the times in the pregnancy, in a non-diabetic pregnancy, we see that morning blood sugar level goes up to 55, 60 normally also. So we should not really be very much worrying about the hypoglycemia during the pregnancy. Apart from that, more important is the monitoring part. If we can't do the CGMS kind of the things, if affordability is not so good or availability is not so good, then better we should ask our patient to at least monitor 3 or 4 times in a day. At least all major meals should be covered with the postprandial glucose monitoring, 2 hours postprandial glucose monitoring after the first bite. That is the best policy for taking the patient towards the best outcome. And usually I find it works well.
Thank you so much. This was a brilliant conversation that we had for 30 minutes. And I'm surprised that, as much as you read in this field, you always fall short, and we are always learning more about treating hyperglycemia in pregnancy. So thank you very much, Dr. Sunil Gupta, sir, Dr. Anuj Maheshwari, sir, and Dr. Unnikrishnan, sir, for sharing not only academic and scientific evidences, but also your clinical acumen and experiences. Thank you very much. Very fulfilling session.
Thank you, Purvi and Manoj, for
Wonderful
inviting
to
me.
be here.
Thank you. Thank you all
Wonderful
of
to be
you.
here with all of you. Thank you.
Yeah.